Welcome, everyone. Thank you for coming. My name is Lauren. I'm one of the educators at IRIS. I am joined today by our Chief Medical Officer, Dr. Ron Gross. Dr. Gross, would you like to tell us a little about yourself?
Sure. I'm a practicing ophthalmologist. I've done that. You can tell by my gray hair that it's been for a pretty good while. And then I've been the CMO at IRIS since 2018. And a lot of, my job is to oversee the clinical side of things and the actual patient care side. So I'm looking forward to having this discussion. If anybody has any questions, please feel free to put it in the chat, probably is the best thing. And we can address them either during or at the end.
Absolutely. So there is a Q&A box that's available to everyone. If you have questions throughout the session, just drop those questions in the chat and we'll do our best to address them. Dr. Gross does have another meeting, so if we aren't able to get to your question during the session, I will make sure to follow up with you individually so that your questions get answered. So we're going to go ahead and begin. This is one of our most requested topics for a webinar, pathology in iris exams. So today we're going to be talking about some of the most common findings. Obviously, our interpreting providers are looking for diabetic retinopathy and macular edema. So we're going to discuss those along with some of the most common suspected pathology findings and something that you may or may not be aware of, emergency findings. They can also detect emergent conditions that need immediate need to be immediately addressed. So we're going to talk about the conditions, how they impact vision, treatments, and the importance of early detection. So that's probably the most talking I'll do during the session. I'm going to go to the next slide, and Dr. Gross is going to begin talking about what it is that the interpreting providers are looking for.
Okay, so this is kind of what the typical picture that you all take, that you send to us contains. And there's this is the fundus, which is the back part of the eye. There are several layers to the back of the eye, and we'll go through those as the pathology comes up. But on the picture, what we see there's certain anatomy that we just need to identify. The function of the retina and of the eye, to be real honest, is to receive light. It then changes that light into electrical energy, which is then transmitted through nerves back to the brain. You actually process a large portion and actually see with your brain. So the retina receives the light. And if you look at it, what we call the macula, that's the center of your vision. That's where all your reading vision is. You can have the macula intact, everything else gone, and you may still see 20/20. If you lose the macula for some reasons that we'll talk about, and everything else is perfectly normal, you won't even be able to see the big E. That information is then transmitted through a bundle of living wires called the optic nerve back to the brain, and that's the way the information exits the eye. This is living tissue, and in fact, the retina uses more oxygen per gram of tissue than any other tissue in your body. It's that metabolically active. So it has to have very good circulation to bring enough nutrients and oxygen, as well as take away waste products. So what we label as the superior and inferior arcades are the major blood vessels that bring blood to the retina itself. So let's go on next and see what can go wrong. So what happens in diabetes? Diabetes does lots of things, as you probably know, but particularly today, we're going to talk about its effect on blood vessels. And the unique thing about the eye is it's the one place that you can actually see blood vessels, theoretically, all the way down to the level of capillaries. So you have the ability to directly observe non-invasively without having to do any X-rays or give any dyes. You can just see what the status of the blood vessels are. And the first thing that happens in diabetes is that the walls of the blood vessels get weak and they pooch out. It's called an aneurysm, where the blood vessel, instead of being of normal size, in one focal area, it actually enlarges. On the left is a color picture, as you would normally do. There is what we call a microaneurysm, which is a very small aneurysm, a small outpoaching that's there, but it's really hard to see. Iris has developed a proprietary enhancement technology that lets us see it better when we look. And on the right, you can see that kind of dark spot right in the kind of at about 9 o'clock. And that's the microaneurysm. You can see it's along a blood vessel, which is the darker part, and then it pooches out in that one focal area. In and of itself, typically it does very little. The wall still works, but it's just the very start, and it tells us that something's wrong, that there's already diabetic changes in the blood vessels, and that if we don't do something differently, chances are that will continue to get worse. So it's really any retinopathy, diabetic retinopathy tells us that it's an opportunity to change that patient's sugar control, because it's saying that it's not good enough and that damage is already present. Not severe at this point, but as we'll see, that's unchecked, that is what will happen. So as the outpouching of the blood vessel continues, go on to the next one.
Dr. Gross, quick question
Yes,
before we move on. Is a
sure.
patient with mild retinopathy likely to have experienced any vision changes at that stage?
Very, very rarely. It is possible if the microaneurysm is right next to the macula, sometimes early on it will leak a little bit, but that's pretty rare. For the most part, at this point, these people are totally asymptomatic. They don't know that it's there. That's the reason we have to look for it. And that's the reason as things change, we're able to determine, yes, this is way earlier than any other really end organ damage that we can detect from glaucoma. Or sorry, I do glaucoma from diabetic retinopathy.
So
Next.
just to kind of summarize what you mentioned
Yes,
earlier, at this point, treatment would likely be focused on controlling the patient's blood sugar.
correct, because there's really no need to treat the eye itself. It purely tells us that whatever we've been doing, if this is new, this tells us that whatever we've been doing isn't adequate and the patient needs more appropriate therapy.
Awesome. And then we can hopefully arrest the progression.
Correct. And even if you get it under good enough of control, it actually gets better, as we'll see.
All right. So we'll move on to the next stage.
Next stage is what we call moderate. In this case, what happens is that the blood vessel not just pooches out, but it starts to leak. And if you remember when you you get your blood drawn and you spin it in a centrifuge, you get the red cells at the bottom and you get the kind of clear to cloudy stuff at the top. It's kind of yellowish. And that's exactly what we see in the retina. When it leaks out, we have hemorrhage, which is the red things, the little red splotches that you see. And then you have the exudate, which is the deposits of the stuff that's in the plasma in the retina itself. Here you are leaking fluid, you are leaking blood. If it affects the macula, it will affect the vision. If it doesn't affect the macula, if the areas like here, there's not much near the macula, there's probably no macular effect. So the patient may well be asymptomatic at this point. They may not recognize any visual change. Again, if you don't get their blood sugars under better control, this will just continue to progress. At this point, if there is an effect on the vision, there is treatment that's available that actually will help the material that's leaked out get reabsorbed. It's not pill. At this point, it's injections into the eye, so it does have a little bit of risk, but it is highly effective. You'll also see at the very bottom kind of a white splotchy thing. That's it. Okay. That's called a cotton wool patch, which is actually where you've had actually an infarct. You've had death of the retina in that spot and it swells up and it turns white. And these are just the things that we typically see in people with moderate diabetic retinopathy. The blood vessels leak and they actually can, if they're totally occluded, the retina that they feed dies. Next. As things get worse, you can see here a lot more blood, a lot more exudate, which is the kind of shiny yellow stuff. And you can see the macula is kind of that darker patch right in the middle. And you can see all the exudates, particularly on the one to the left, are much closer to that. In this case, I think the patient definitely would have decreased vision. because of that. And again, if you can get their sugars under control, and actually we have therapies for the eye itself that can act on this and make it better. It's not, it still is injections. It's not simple, but it does provide them the ability to improve over time. Just getting their sugars under control will help. It just takes a long time. The medication that we use will actually allow it to act quicker. And again, at this point, we would presume that there is definite decreased vision, and and what we really are concerned about is what happens next. Next. So this is severe disease, proliferative diabetic retinopathy. What happens here is that there's, as I said, the retina requires the most oxygen in circulation than any tissues in your body. And if there's enough damage to the blood vessels, they're obviously not good, the retina is not going to be able to get enough. So the body's response, which is not unique to just the eye, but is pretty much anywhere, is that it sends out a signal called vascular endothelial growth factor, for all that's worth. And it signals the blood vessels to branch off and make new blood vessels, which sounds like a really good idea because that would obviously allow more fluid, more blood to get there. Unfortunately, the blood vessels are not normal and they are not in the places they ought to be. They are much more fragile and they're under much different structure than the normal blood vessels. As a result, they leak enormously. On the right-hand side, you can see that big swath of kind of dark brown right there. That's actually blood that is leaked into the interior of the eye. All the other white kind of things are all fibrosis and traction that are causing damage to the retina. At this point, this patient has severe vision loss. Probably, maybe they can see the big E or a little bit better, but not much better than that. So this totally deforms. And this, though we can do surgery in this case to fix it, it's never going to go back to where it was. It may not, from a visual standpoint, may not improve at all, even if you can break through all this scarring that's occurred and cleared out the blood, the function still may not return. So that's why it's so important to be able to treat these people before they get to this distant end stage of the disease, because it's probably not able to be gotten back. So that's why it's so important. And again, there's very good data that the better you control the sugar, the less likely that they will go through this progression, even starting with retinopathy or have progressive retinopathy. So really important, their care is of their overall diabetes, and realize that the retina is just reflecting the rest of their body. The same things are probably are most likely and probably are at work in their cardiovascular, in their heart blood vessels, certainly in their kidney with kidney failure, with their nerve blood vessels, with neuropathies, peripheral vasculature, all those things. We're just not quite as sensitive at picking up in those organs as we are in the eye. So that's why it's so important to be able to know the status of the patient.
So if
Next,
it's happening in the eye, it's happening in other parts of the body.
everywhere.
Absolutely. We do have a quick question before we
Sure.
progress. One of our attendees is asking about the nature of the vision loss. So their question says, when you say vision loss, do you mean that the patients are seeing blurry or dark spots? What does that vision loss look like?
It is blurry. If it's just blood or fluid in the macula, it's blurry. If there's blood that, like we see here, actually inside the eye, it actually will, they see it. They see big black splotches passing in front of their eye and moving in front of their eye. So it is both, depending on what the severity of their disease is.
Absolutely. And if left untreated, diabetic retinopathy takes all of their vision. Is that correct? Complete and
Correct.
total blindness?
Correct. You will, if you don't do anything, this will actually progress. We'll show pictures later of a total retinal detachment. It basically takes off the retina, all scars into a little ball, and is totally non-functional. We're talking no light perception, not able to see anything. again, depends on how severe there is, what the rate of progression is, and how old they are. But yeah, if they live long enough and their disease is bad enough, that's where they'll end up,
Thank
untreated.
you. All right, we'll go to the next slide.
So I was talking about what happens in the macula, and that's what we call macular edema. That is swelling in the macula. And it's typically due to the blood vessels leaking. And as we've talked about, it can be blood. It can be the yellow stuff you see is actually fats, lipid that's in the blood that gets deposited. And then you can just have the clear fluid accumulate as well. We can't see clear fluid because it's clear. But typically what we know is that if these other things are there, the clear fluid is there. What happens is that when you have edema in the macula, it changes the structure. There's a very well-defined structure of the retina. There are 9 different layers of the retina that allow the light to be absorbed and then be processed before it heads back to the brain. And if you disrupt that, that is by swelling, it doesn't work as well. And the more disrupted it is, the more poorly it works. And that's why it's so important if we identify this. And again, this is largely treatable. It's not 100% treatable because some is so severe and some doesn't respond. But the vast majority of these, particularly if you find them earlier, are very treatable and they can return to 20/20 vision with adequate control of their blood sugar and adequate treatment from the eye standpoint. So that's why it's so important. We want to know the severity of the diabetes just because we need to know that. But really the important thing is we want to know, is there macular edema there? Because that's something that if it is there, we can treat it, we can reverse it. And if we can maintain a better control of their sugars, we can it won't reaccumulate. So they end up, the earlier you get it, the easier it is to treat. And that's why, again, it's important to check these patients to make sure we know their status so we know what to do and we can get effective treatment if we need it.
Does macular edema only develop in individuals who have retinopathy, or can it develop by itself?
There are other causes. Some people get it after cataract surgery for a while. There anything that causes fluid to accumulate will do it. There are some cases of out of control high blood pressure can do it, but by far the most common cause is diabetes.
All right. Next slide.
So that's the diabetes side. Go back one just for a second, just for comparison. Okay, if you look at the optic nerve, which is that kind of white disc, okay, you'll see that it's kind of round, and in the middle of it, there's a little white circle, and then around the white circle, there's kind of pinkish. It's supposed to be pink. Take my word for it. But the pink is actually the nerve tissue that's leaving the retina and heading back to the brain. The white area is called the cup, and that's kind of the leftover space because some people's openings for the optic nerve are bigger and some are smaller, so there's always a little bit of leftover space. What happens in glaucoma is that those living wires that are going from the retina back to the brain get damaged. And here you can see glaucoma on the left particularly shows it well, whereas in the other one you had kind of a small little white disc in the middle and a fair amount of pink stuff. Here you've got a big white disc with almost no pink remaining. And that's what happens in glaucoma. Glaucoma typically affects the peripheral vision, not the central vision. Most of these people until very late in the disease are asymptomatic because it progresses very slowly. So again, just looking at the nerve, in these cases, yes, it'd be simple to know, we would know they have glaucoma. But I think that again, as long as the information is there, we want to take advantage of it and they can identify. For glaucoma, there are other tests that need to be done to confirm the diagnosis. Those aren't really within the realm of what we can do or what would be done outside an ophthalmologist or an optometrist's office. But if it is suspected, it does make sense. This is the leading cause of blindness. Diabetes is the leading cause of blindness in working age individuals. Glaucoma is the leading cause of blindness in older patients. So again, very important that we recognize it and take care of it as we need to.
Absolutely. And just to provide an additional context, glaucoma is the largest percentage of the suspected findings in iris exams. So this is definitely something that's being identified quite a bit in those images that our clients are capturing.
Right. We can't diagnose it, but it certainly we can. And the reason we say it's suspicious is because this alone doesn't allow you to make the diagnosis. You need other you need other testing to be able to do that.
Absolutely. And that'll be true for the remainder of the conditions that we cover.
Correct. Next. Cataracts, very common. Um, Cataracts are when the natural lens of the eye turns cloudy. You have a lens in your eye that focuses, and when you're born, it's crystal clear, and through your entire life, it starts turning cloudy. Cataracts are really when the cloudiness is bad enough to where it causes blurriness and glare. It's very fixable. It does require surgery. The surgery I just found out, is the most successful with the highest satisfaction rate of any surgery that's done anywhere in the body. But what it does is it makes our view, the same view we have in, is the same view the patient has out. So like you can see on the left, it's very blurry compared to the images that we've been seeing before. And that reflects that the patient is seeing that much blurriness too. There are other causes that can cause this blurriness. So we can't say definitively, yes, this is a cataract. There are other things that can cause blurriness to occur, but by far the most common thing is cataracts. And if this amount of haze and cloudiness is present, the patient ought to be seen so that they can make sure that that's not, it is cataracts or what underlying it is. It's important to know that if the image that you take is is out of focus, it may kind of mimic this. So it may be difficult to tell whether this is blurriness due to not having proper focus or from cataracts. So all the more reason why, at least as best we can get as crisp a picture as we can get. Next. Macular degeneration. Macular degeneration, again, is a very common cause of blindness, particularly in the elderly. There are two kinds. There's dry. Until very recently, there was no treatment. As of now, there is a treatment, though I must admit it hasn't been nearly as effective nor nearly as useful as we thought it was going to be. But in time, I'm sure there will be. And you can see on the right, there's things look relatively good. The image on the left. On the right, you can see how much loss there is. That part only from about the middle to 9 o'clock is the only part of the retina that remains. Everything else is totally atrophic, does not work. It's just, it's totally, there's, again, there are some things, there are vitamins that people can take that have shown a little bit of effect in minimizing this. The most important thing is that they need to change if they smoke, they have to quit smoking, and some other factors that can be gone over. But there is potential to slow it down somewhat by changing some of their lifestyle decisions, as well as some vitamin therapy that's of some modest amount of help. But again, very common. And as long as we're there, we look for that as well. Next. Okay, wet AMD. What happens here is we talked earlier about blood vessels due to diabetes. There are other reasons that blood vessels appear in the retina. And actually, in this case, they're under the retina. Some of the retina gets its nutrition from underneath. And these are blood vessels that break through. In general, this is very symptomatic because this can affect anywhere, but is much predisposed to being in the macula. Typically, these people have severe vision loss or substantial vision loss. And again, this is treatable to some degree. The same medicines that we use to treat the blood vessels from diabetes are the same ones that we can use to treat this. And there is the potential to improve. You're never going to get it back to normal, depending on what part of the retina and the macula is affected, but you can certainly keep it from getting worse and try to improve it as much as possible. So again, another reason that as long as we're there when we see blood, and sometimes it's just scar tissue. By the time it's scar tissue, it's too late. But if we can see fresh blood under those circumstances, we really can intervene and make a substantial improvement in their vision. So again, as long as we have the picture, we might as well make the greatest benefit from it. Next. The last things are things that are rare but really important. If within the image that we have, we see these big brown dots, there are a couple of possibilities. Could it be a nevus, which is just a freckle, which happens here as well as it does everywhere else, or is it a melanoma? And obviously those are quite different. In order to differentiate those, again, you need other testing than just a picture to allow us to do that. But very important that if you, the same, the risk of melanoma, these are life-threatening things if they're not identified. So if we have the opportunity, we see one, it's not something that's emergent, that is today or tomorrow doesn't make any difference. It didn't start yesterday. But it is something that's really important for them to follow up on to make sure that if it is a melanoma, it can be treated. If it's just a nevus, then it needs to be watched the same way your large freckles that you might need to watch on your skin as well. So again, if we see it, we're happy to, it's important to identify it and be able to act on that to minimize the risk to the patient's life. Because here we're really talking about life. If they get a melanoma, that can certainly be life-threatening in the eye as well as everywhere else. Next. And I think this is a retinal detachment. We talked a little bit earlier about how the retina can totally come off the back of the eye. Here you see no structures because it's just all wadded up. You can see kind of the traction and the scarring that's occurred, or those big white bands. Things are of different focus. Again, this is something that's treatable. In general, it does require surgery to treat it. But if you get, depending on how severe it is, how long it's been off, this is something where you can restore substantial amounts of vision if it's surgically repaired. So again, we find it needs to be addressed quickly. And I think next is last. Here you can see, whereas before when we were looking at the optic nerve, it was a kind of round oval disc that had very well-defined margins. It was a very sharp margin. Here you can see it looks much fuzzier. And the reason it looks fuzzy is because the intracranial pressure is elevated, and it has blocked off the flow through the optic nerve, which has caused things to back up and caused optic nerve swelling. If it's in both eyes, it almost always is due to increased intracranial pressure. That could be a tumor, that could be a hemorrhage in the brain, that could be other diseases. The important part here is it's not just the eye, it's the brain, and some of these things can be life-threatening even immediately. If this is bad enough, they can die from elevated intracranial pressure around the brain. So this is one of the things that we designate as an emergency. If we see it immediately, we have a cascade that's in place so that we can, literally as soon as you possibly can get it, we'll get the information to you so that you can contact the patient. And in most cases, the patient ought to go to the emergency room because, again, from just the picture, we can't tell what their risk is, but there is some risk that this could be life-threatening in a very short period of time. And if that's the case, we sure want to do everything we can to avoid that. So we've set up that cascade. You should be familiar with it, where our grader lets us know and we let you know with specific people so that this can be addressed immediately. It is possible that this is only in one eye. Sometimes you get optic nerve swelling for other reasons, and that's probably not, in most cases, that is not an emergency. That's something that's only affecting one eye. And for that reason, it's not an emergency, but it is still something that needs to be addressed, but not quite as emergently. So we differentiate that so that we don't send people who have the problem in one eye. We really just want the emergency for those things that truly are emergencies and are life-threatening in a very short period of time. So I think that's all we had. I think that was the last slide.
That's correct.
Any questions before we finish?
While we're waiting to see if there are any questions, I just want to reiterate, Dr. Gross, that we are so appreciative. This is something we get a lot of questions about it during training. People are very curious about how these conditions affect patient vision. You've given us a lot of great information. And I think one of the things that I heard a lot throughout your presentation is the earlier that we catch these conditions, the easier they are to treat, the likelier that our patients don't have to experience significant vision loss. So I just want to reiterate that our clients are doing great work by providing these screenings to their patients so that they don't have to lose their vision unnecessarily.
Right. And to be real honest, the whole reason Iris was started, it was started by a retina specialist. And he and I worked together from very early on. And it was because it's really very frustrating to us that people with diabetes were walking into our offices who are essentially already blind, and there was nothing we could do to make it better. And so the whole idea here is to be able to find these people early. We know they're supposed to go to their eye doctor every year. We know that at least half of them don't do that. And from your aspect, even if they go, you probably don't know that they went or get the report. So the whole idea of our whole solution is to make it as easy on the patient as possible, so that we can make sure that if it's there, we know about it, we catch it as early as possible and get them plugged into the system to where we can minimize their risk of getting worse and treat them as necessary.
Absolutely. I don't see any additional questions, so we're going to go ahead and conclude the webinar. Again, thank you so much, and we appreciate all of
Pleasure.
you joining us.
Thank you. Have a good day.
Have a great day, everyone.